My name is Judy Lento. I'm an independent medical practice management consultant and also the director of client relations for a company called On-Site Mammography. And I recently received a fellowship on big data, revolutionizing outcomes and the healthcare marketplace. Okay. One of the first things that I found, and the reason I really started here, is using data analytics, decision making. Yes, that's what, using data analytics, yes, I really believe it, that even when we use those P&Ls in our practice to make decisions, are we going to buy something, are we going to do something, we're going to hire a doctor, whatever it is, we're somehow measuring some sort of data of one source or another. So one of the things I did is like, really, what is data? It's a bunch of disparate information that we get from multiple sources. You know, they're coming in now. I mean, there are new tools. There are patient engagement tools that are being used in the marketplace. There are gadgets that people are wearing that are sending information back to the physician's practice that he needs to put in the chart as well. There's all types of information coming into the chart. And what do we use it for? You know, we have to take a look at that data. Right now it's coming in, we put it in a chart, but does anybody really look at it or measure it or take the reports and make anything of it? So we use it actually for our payer contracts, patient care, physician-patient interactions. Those are the things that we can be using it for. These are some of the things that Derek was talking about that CMS is reporting back to you on. They're telling you the information that you've already given them. Then the other thing I looked at is analytics. So what I found out, I looked at IBM's definition of analytics, and it made the most sense to me because it was a systematic use of that data that we're getting and utilizing it in some force to help, you know, drive our decisions or, you know, make better choices within our practices or with our patient care, things of that nature. And one of the things that I found was very interesting is they described it as descriptive, predictive, and prescriptive. So there are multiple ways that we can use the data that comes into the practice. Okay, these are some of the decisions. I'm assuming many of you are practice administrators in this room. How many of you have had to make decisions as to whether you're going to hire a mid-level provider or a new doctor? How far out does your schedule go? How far in advance does somebody have to make an appointment to get into you? Are your schedules full every day? You know, those are some of the things that you're looking at. Do you continue to offer a particular service? Maybe you're offering a service and you're getting reimbursed $90 for the service, but it's costing you $120 to actually perform the service. How do you know that? If you don't look at the numbers that you're actually getting in and you don't look at the reports that you're generating daily and reporting to others, how do you know those things? So do you build a lab? You know, what's going on in the labs today? How are you getting paid? Is there payment for it? Should we do it? Should we add a center like mine, a mammography center to there? What would we get paid to do mammography in our office as opposed to sending it out? How do you decide? Do you insource something or send it out? It's based on some sort of analytics and reports that are already within your system that you need to utilize to make those decisions. This is some of the things that I was looking at, and many of you, I'd like to get like some feedback from some of you. How many of you are administrators in this office or consultants? Do you use these things? Do you look at them pretty much daily? All the time? How far out is the practice book? Is scheduling consistent? And then you look at it by payer. And what happens if Blue Cross Blue Shield sends you that report card and they say you're in the 25th percentile compared to your peers as far as efficiencies are concerned? Why not be prepared and be ready rather than have to get ready when those things come to you and they're telling you that you're not efficient? You're not efficient based on some small period or some measurement that they looked at from you. But if you take a look at the report, like something that Avisena can give you here, our company and whatever, they can give you reporting back and you can take a look at how you're doing overall and show them that in general you are using the data that's coming in and that you really are efficient. Just the period that they may have measured or the small amount of patients that they saw may not have looked appropriate. However, this is what you're doing in the background to show that you're being efficient and using the information to improve the efficiencies and peak them in your practice. Payers discern your proficiency as a provider based on data collection, CPT codes and ICD codes that you already give them. You already have them. Because talking about CMS reporting, why not use them in advance before you're sending them out to them? Why not utilize them internally and sit around in a discussion groups with your providers and your staff and utilize those things to help you make better decisions? Tiered plans, what happens if they send you back a report and tell you you're not efficient and they put you in tier 2? So the patient now has to pay more to see you as opposed to another provider. What is it that you can do to protect yourself? How do you use the data that you're producing on a daily basis to protect yourself against the changing healthcare marketplace? Are any of you doing things like that already? Are any of you doing things like that, predictive modeling within your practice, utilizing reports? You're not? But
things, identifying where to go, yes.
You are using that?
Yep.
Have any insurance companies, with any of you guys, have any of the insurance companies sent you report cards that you didn't agree with as of yet?
Yes.
United Healthcare, possibly? Yes. Yes. One of the things is I sit on a focus group with United Healthcare nationwide, and they meet the first Wednesday of every month. And as of right now, they are actually paring down their physician. They're paring down their physician numbers, and they're firing physicians, and they're tiering physicians, and they're making it difficult for them. I feel at this point, and I think the reason that I was so interested in the utilization of data that we produce within our practices is because I felt that it's the only tool that we have to fight back, is to be able to show them our numbers or what we're doing internally to improve our processes within a practice. Harness data. This is some of the things that Derek was talking about. It's really important. We're getting data now in our practices. There are patient engagement tools. There is a wonderful tool that I saw out there. It was called the Real Age Test. I don't know if any of you have looked at it, but it was introduced by Dr. Oz. And one of the things I thought about when I took that test, my age chronologically is 63, but when I took the test, I found that I was somewhere in my 50s, and that you can work on it and improve your health. What about the tools, those type of tools? Those tools are producing data in the background, and that data is being reported somewhere. Somewhere that data is being held. How is that going to affect us? How are we going to manage that data when it starts coming into our practice? What about the Fitbits that everybody's wearing now? That's also data that's out there. That's data that's now being harnessed. Google is looking at that data, and Apple is looking at that data. All of that data is eventually going to come to a physician's practice. How's he going to manage it? What's he going to do with it? And how's he going to harness it and organize it and analyze it to be a useful measure within there? How are you going to deal with this bombardment of data? And what data is important? What is the important part? How do you get rid of what isn't important and harness what is important to help you have further insight into the future of your practice? And I truly noticed in the information that I've been gathering that it could be somebody else out there besides yourself that decides whether you live or die, or you stay independent, or have to join a hospital center or a larger practice. So why not be prepared yourself internally to make those decisions based on your own internal measures as opposed to somebody else reporting it back to you? So one of the things that I did notice in studying this past year is what everyone is trying to do is kind of standardize the healthcare marketplace and tailor it in a direction. I feel like in some way we're like in a maze and being somehow directed by them paring down the number of physicians that are available. If you have United Healthcare as your payer personally, or you have Blue Cross as your payer, and you want to stay within what you can afford, you're going to have to go to the doctor that's part of the plan. And you want to be one of those doctors that are part of that plan. Evidence-based medicine models are being used to measure you. How are your physicians coding? It's not a matter of what's actually in that chart or what they did. As this morning they were talking about in there, it's how your doctor codes it. How does he code it? How does he make the insurance company aware of what he's doing in that exam room? And it's all in some sort of a data that he puts out there. He's got to check the right box and make sure that not only did he do the work, but that he's reporting it appropriately in the right language. Value-based contracting, which is something that you talked about, is also going to be on the data that you report in some sort of a a form. How are you doing, and how are you showing value to the insurance company? Are your patients being readmitted to the hospital very often? Do you have a high postoperative infection rate? Are your diabetics A1Cs in control? Is the majority of your patients obese, and if they are, what are you doing about that? How are you educating your patients moving forward? Oops. I thought that I wasn't sure what Derek was going to be talking about, but I thought that my talk could be somewhat more interactive, amongst all of you, kind of some of the things that you've been thinking about regarding data and analysis and what you think data is and how you think that it can help you moving forward. Anybody have anything that they're doing within their practices that they would like to share? Particularly any reports that they're running to help them make decisions in the practice based on their PM systems?
Well, we actually combine some of the stuff from the practice management system with hospital data.
Mm-hmm.
We're neurologists.
Mm-hmm.
The biggest impact I think we can make for insurance companies is keeping people out of the hospital, or once in the hospital, to make sure they get diagnosed quickly and whatever ancillary testing required done early so that the length of stay is reduced. So we take that data, hospital data that says the length of stay over time, we show that we've reduced it, so that we can talk to the insurance company about, look at the total cost.
Right.
Don't look at my per click fee.
Right.
Because my per click fee may be higher than everybody else's, the result of which is there are less clicks for everybody else when I reduce the length of stay. So we're trying to use that kind of data. Insurance companies aren't prepared to have that discussion because they just think per click.
It's a very big thing out there with the insurance companies, and actually working very closely over the past 6 years working with United Healthcare. That's exactly what they're looking at this particular time. They're looking at that per click, and they're looking at how much are you costing them, every day, and not understanding that. I ran a big neurology practice as well, so I know that the length of stay is a huge is a huge thing. But how are you, do most of you recognize the data that's coming in? All of us as administrators have purchased systems throughout the course of our years as administrators. You purchased a voice over IP system or a PM system or an EMR system, all of these things to meet a particular need at that time. None of us could predict that those things would have to be tied together at some point. At this point in time, what we're doing is actually tying those things together and utilizing them to make better decisions moving forward. So that's where that predictive analysis is. How are we taking the disparate information that we had, pulling it together, and making decisions for our future rather than allowing insurance companies or CMS to make those decisions for us? And if we choose to join a hospital, or we choose to have, to build some large practice entity, or we would like to stay that independent mom and pop practice, what tools do we have to use to leverage to keep that status? And those are the things that I thought maybe, as a team, we could kind of talk about. What some of you, are most of you in hospital practices? Are you in private practice? Are you in large practices? Have you gone through a merger? Most recently, when I left, I've been in women's health mostly, and then was recruited to neurology and ended up running women's health and neurology. But one of the things that I saw is that OBGYN, which was women's health, was being driven to become these large mega practices because they couldn't negotiate independently. So that's what was happening in women's health care. But how do you make those decisions? How do you prove that you're efficient? I think one of the ways that you can prove that you're efficient is by somebody who is making it less expensive for them, by having good systems in place that actually check the benefits and eligibility before the patient comes in, so you don't have to make phone calls to the company. When you make a phone call to Blue Cross or you make a phone call to Aetna, it costs them money. They need somebody on the other end. So how do you do those things? All of those things are somehow analytically, they're coming to you if you know how to utilize those tools and work with them and use them to their best advantage. But are you doing that? Are any of you here in hospital practices? Are you in hospital practice? Independent? Anyone in hospital practice? Have you always been in hospital practice, or is it something?
It's been both.
It's been both? What was the decision to join?
I've always been with hospitals for a while.
Anyone here in a big mega practice? What about you, Mary? Now, what are you doing now? You're working with multiple practices. What are you seeing in the field?
I'm working with my full-time day job is with a health system. We're geriatrics, and we're actually I've got my foot in the hospital because we're in our hospital on campus and all of our outpatient services. So we're struggling with where our physicians should be placed in order for contracting. Right now they're just employed, but should we break out and do more of a physician model?
How are you using that?
And gather that. How are we viewed in the eyes of our employees?
Have you had to change systems, or have you been able to pull together disparate systems to make some sort of,
We're antiquated, so we have to replace systems because it's all data-driven. We have to have a better handle on our data and do it, much more effectively, efficiently.
Do you think that would help, like having that information at hand on your?
Absolutely.
I have a question. Going before the day-to-day is only as good as what's being put into the system. And we've touched on MRA earlier today and now, and physicians really haven't been educated on the importance of, they know this is what I have to do to get a level 4, and that's going to bring me X
Right.
amount of dollars in revenue. The managed care companies traditionally, and I've sat on committees from some of them where they go, we want to get from 3.5 stars to 4.
Right.
And never once did they bring up HCC and diagnostic coding and ICD-9s and the importance of this stuff. So we're getting into this now, and I'm trying to get my doctors to understand.
Right.
No, this is big. This keeps you out of networks because it could be determined you're a high-cost provider.
Absolutely.
Because nobody reads the medical record. It's in the claims database.
Right.
So how did you educate your physicians on, look, it's equally important to get the correct diagnosis and the comorbidities and all that in there with the mindset of, no, you're not going to get $201 instead of $190.
Right.
But in the long term, it's going to put money in your pocket.
Trending, because one of the things that I found reporting did, and analytic, analysis, kind of data analysis, was by showing them trends of the way they practiced individually. Because one of the things that I did see with United Healthcare, it didn't matter if you were part of the biggest mega group there was. They were looking at you, Dr. X. They don't care what network you're in and how great those. They're going to look at you and they're going to fire you. It doesn't matter that you're part of such and such hospital, and it doesn't matter that you're part of such and such mega group. So what I did with my physicians at the end, we had been on an EMR from 2005 or 6 is when I took my private practice into EMR, and I started looking at things, and then I started sitting with them on a monthly or bi-monthly basis and showing them, Dr. So-and-so, how could every one of your patients be a 99214? It didn't make sense. It's like 90% of his patients were 99214. How did that happen? And then we started looking at, I had the doctors, do peer-to-peer chart reviews. They were not happy about it. I mean, I thought I was going to lose my job over it because they were always fighting. We would be in a room and, who are you to tell me or whatever. But one of the things is he had all those 99214s, but they weren't supported in the background. He did not have the information in the chart that supported a 99214. In some of the cases, he was lucky if he had a 99212 in there. I mean, that's how little information he had in there, especially just converting to an EMR. He clicked this, and this, and he said it's a 99214, and that's how he did it. So I believe that it is education, and it's constant. It's not one time. It's multiple times and multiple reports. I found working with male doctors, the female doctors like numbers, the male doctors like me to do all kinds of graphs and charts. So if I could give them graphs and charts and show them how they were trending, it made sense to them.
But
They didn't still.
that's on the CPT side, which I can get the docs to understand the CPT because they know a level 3 base,
Right.
level 4. But then on the other side with the ICD-9s and the HCCs and the risk adjustment and all that, to get that to click because it doesn't make any difference immediately when they send out a bill.
Right.
They're going to get the same amount.
Correct.
But it affects the Medicare Advantage plans.
Oh, absolutely.
And the doctor's future reimbursement or being in network.
So you're saying that they weren't diagnosing it correctly or
I'm saying
overdoing.
it's not uncommon to go ahead and take a look, and I'm with cardiology.
Right.
To run reports and go, really, your number one diagnosis is uncomplicated hypertension. And they go, no, patients are, well, yeah, they're really sick, and it shows it in the medical record,
But it's not supported
not
in the
on
code.
Right.
I think, to me, I think I would show them reports and show them, in some sort of graph or whatever, that this time they're using that uncomplicated code more often than they should, and that insurance companies are going to be looking at that. And they can't see what's in the medical record. That's the part. I said insurance companies are making decisions on our futures as administrators, as practices, and where we're going, and they're only utilizing what we're already giving them. So why not us utilize it first before we actually give it to them? So I think that's it. I think it's continued education on the physician side.
I was going to say, being hospital-based, now the hospitals are looking at the RVUs.
Oh my goodness.
That's like the big thing now.
I had 8 neurologists and 5 OBGYNs, and all they ever wanted to know from me, they did not care at all about what the code was. They did not care at all about what the diagnosis was. How many RVUs, they wanted me to report to them 2 times a month in the middle of the month, so they knew how many more RVUs they needed to make to get a bonus. That was all they ever, I gave them a whole lot more that they didn't like, but that's all they really wanted to know. And that's very difficult to get past because they're very money driven, and we look at the politics of it, and we look at what's going on in the background, and you try to tell them this, and they don't think that this is going to affect them until that first doctor gets his letter that he's in the 25th percentile of efficiency, as compared to his peers in the nation or right in his area, and that he stands a chance of being dropped off the panel. That's when it becomes serious to them. And you don't want them to get to that level. So you just keep telling them, this is what's happening in the marketplace. It's very, very frustrating being an administrator, trying to show them these things when their head is in this other direction. You have the same problem. They always want to know how much money they're going to make.
So the hospital is
looking at it.
Your RVUs, that's all they want to know.
Mm-hmm.
That's how they're judging them now.
Are you finding the same thing being in the consulting side, that they're looking at the RVUs? And that's another thing that's really important to all of us as administrators, is actually it's another way that we can look at it and report back to the physician. Like, I've had physicians, young physicians, who are telling me they are so busy. I had 17 patients on my schedule today. This is an OBGYN. I'm like, an average OBGYN sees 17 patients just in the morning. You're not busy, doc. I'm like, I'm really sorry that you feel so busy, but you're not. So I believe that these reports and the information that we can garner from our system helps us in so many ways to show physicians, providers, but also insurance companies, kind of how we're doing, internally, harnessing that internal data. Did you have?
No, I'm an independent consultant, and I've had where the insurance company would come in, check, and this one doctor is a pulmonologist. He's only going to put COPD or asthma. He's never going to put that the person has hypertension, diabetes, anything.
No comorbidities, huh?
No, he feels that if he puts down that the patient has diabetes and he doesn't do anything with that diabetes, that he's legally, the possible malpractice or something, and I can't get it into his head. He's the most stubbornest doctor, but he's only going to put the diagnoses for why he's treating the patient, and he's never going to document what everybody else.
Are most of you using the data that's coming into your practice to support your talks with your physicians? Are most of you showing them the reports and whatever? What if your doctor said when you show them that they're not coding it correctly, like that ICD-9 code? And now they're going to ICD-10, which is even going to be more specific.
Well, they sometimes go, okay, well, the system, it's just easier in EHR. This one's easier to choose, so change the EHR, and which we're working on all that. The main thing, though, is getting them to understand the importance of it and how it's going to currently affects them, and in the future, because it's not it's not CPT, it's not where you're getting this much
Right.
money. It's
How are you
and it's never been
diagnosing it?
explained to them before.
And I think, I mean, I believe that that's job security for most of us who are educated in health administration and, you know, and business administration. It's going to be our job in the future to try to bring back this information from the MGMAs of the world and try to educate our physicians moving forward, or bring them to these type of conferences, because it's probably the most difficult plight that we have in front of us, is educating them and making them understand, and especially moving to ICD-10. I mean, this is going to affect their payment. They always thought it didn't, because basically they were paid on a CPT code. But now, you know, they're also going to be looking at those ICD-10 codes and how the doctors for value-based contracting in the future. So although it might not affect them immediately, but overall, when they're looking at the physician and how he codes and what his diagnoses are, that's going to be his contracts of the future, and it'll be dependent on that.
Well, and this all hits each individual practice. And I guess I have a question probably for Derek in terms of how does the ACO look at, or how do they deal with making sure that they have a complete diagnostic set for a patient in terms of the MRA score or the Hicks, whatever that is?
Well, I mean, a lot of, you know, an analytic software will provide, should provide an MRA score for your population on how you're coding. You know, I'm not aware of one that identifies like opportunities. You know, you kind of have to look at your codes and the doctors and see how they're coding and kind of figure that out. I think, Jeff, you're doing the right thing. You know, if you can put those weighted codes into your EHR, that's the best thing on your diagnosis preference list. And then there also is a documentation component to it as well. So if you use an MRA code, you do have to have certain criteria inside your node that supports that, you know, in case you're audited.
Right.
But yeah, I mean, ACOs, I mean, right now, you know, an MRA score affects your ACO benchmark. So Medicare will come back at the end of the year, they'll bump your benchmark up, and if you're not coding, they'll drop it down too. And that's the same thing they're doing with the value modifier. So, you know, the thing I tell physicians in an ACO, I say, look, it's great for the ACO. You get more money in shared savings and, you know, things that we can do for the administration side from that money. But also your individual MPI is going to be tied to that value-based modifier, which is a risk-adjusted utilization. And that goes right into MRA score and patient satisfaction.
So, and all of those things are coming in some form of data
Yeah,
that we have, that we're reporting to them,
Yes.
but yet we're waiting for them to report it back to us on how we're doing. So that's really where I'm looking at things and saying is, why can't we, you know, as administrators, learn a little bit more how to harness the data that we're giving out. They're not telling us something that we don't already know. We're telling them something that we don't know. So I'm saying that we can be prepared ahead of time so that when they come to us, we have the data that we gave them that we can leverage back to help us retain our status in the field. So I believe that for, you know, what you're facing, it's just going to be continued education, and it's ongoing education, because guess what? Once we get this down, somebody's going to come and change the rule again. I mean, that's what's happened for 20 years in healthcare. I got it down. I was like, gee, I know this. I'm going to work with my physicians, whatever. And then next year, guess what? Remember what I told you last year? Forget that. It's this. That's really, you know, that's really what's happening. Do you find too that you know, networks are being pared down?
No, I've read about that networks are more cost effective,
Right.
without suffering the quality or patient satisfaction.
Oh, come on.
But that's still infancy, I think. It's coming.
Well, I already got a call from Arizona where it was happening. There was a bunch of OBGYNs that got letters that they were being let go. They had 3 months, and that they were being dropped off, you know, UHC. I mean, that is a tremendous amount of their business. And why? Like I said, we could be utilizing the tools that we already have, and also being prepared for the tools that are coming. I think it's going to be very important for us as administrators or as consultants to understand that the tools that we already have and how to utilize them, but also be aware of the tools that are coming and being introduced, and how are we going to utilize that along with the tools that we already have to make better decisions and to peak our efficiencies in the way that the practice runs, so that we have that to leverage back as the healthcare marketplace changes moving forward. Are there any questions or any insights that you brilliant people have that you want to share back? Any doctors in the group? No. It's really hard on them. It's kind of good that they're not here. It's kind of a scary environment. But anyway, that's right. Thank you very much.